Dr. Murtaza is there. So Dr. Murtaza will be talking to us on peripheral ulcerative keratitis, infectious and non-infectious. Dr. Milind is not there. Gunjan? Oh, sorry.
Who is the next speaker? Please load your slides. Yeah, Murtaza, you can go ahead.
Thank you, Team Scientific Committee, All India, and Vidarbha Ophthalmic Society for giving me this opportunity. So I will be presenting my talk on peripheral ulcerative keratitis. So whether it is infectious or non-infectious, let us clear after this topic. So no financial disclosure. So what is PUK? So apart from its peripheral location, it is a rare inflammatory condition of the eye and associated with autoimmune diseases, and nearly about 50% cases are associated with collagen vascular disorder. And sometimes this peripheral lesion can be an initial presentation of systemic disease like granulomatosis with polyangiitis GPA or polyarteritis nodosa. So whenever the PUK name comes to our mind, and what we see a classical picture as a crescentic shaped perilimbal ulceration with subepithelial infiltrate at the overhanging edge. And the progression is mostly circumferential, whereas it can be a centrimetal also. So associated features, what we can see in a PUK is a presence of plus minus scleritis. So whenever a systemic involvement is there in PUK, you will get a scleritis because of involvement of systemic vessels. Then you can also get an antechamber reaction that can lead to a hypopyon in case of a peripheral ulcerative lesion. Now to manage, how to manage is to know the etiology. Now before starting management of a peripheral ulcerative lesion, one should be thorough with what the investigations and to know what is the etiology behind it. Because systemic associations are there, and PUK in case of rheumatoid arthritis suggests switch from synovial microvasculitis to systemic vasculitis. As well as both PUK and scleritis association can be lethal, and the survival rate is less than 75% in case of relapsing polychondritis. Also, in some cases, PUK can be a very rapidly progressing, leading to perforation of the cornea. So what are the possible etiologies? So the etiology can be classified into local as well as systemic. Now coming to the local causes, what can give rise to a PUK-like picture? So it can be infectious. Bacterial causes like streptococcus, gonorrhea, Murtaza, Haemophilus, fungal, viral, and acanthamoeba. You can see in this picture the peripheral ulcerative lesion and corneal scraping giving us to a fungal filaments. As well as adjacent picture, if you don't do a corneal sensation test, then you will probably miss the herpes keratitis in this case. Now coming to the non-infectious causes. So non-infectious causes are traumatic due to chemical injury, burns, which can lead to limbal stem cell deficiency, eyelid and eyelashes abnormalities like entropion, ectropion, misdirected lashes, lack of thalamus, neurotropic keratitis where the healing is delayed and you should pick up early, and local autoimmune allograft rejection. This was a case of exposure keratopathy, particularly involving the inferior corneal limbus with superficial vascularization. And this case was managed just by lubricants and antibiotics, and you can see it started resolving within just 3 weeks. So there also can be another entity called as keratoconjunctiva or dry eye syndrome, where there can be due to stromal dehydration you can get a Dalen, and there can be a peripheral edge infiltrate, and then you can miss it as a PUK. One should see the loss of corneal luster and should also evaluate for the low tier meniscus in this case. Treatment will be aggressive lubrication and immunosuppression support in cross consultation with a rheumatologist. Then this is a classical picture of a marginal keratitis. You can see wherever the lid is touching the cornea, you can get such a picture of a marginal keratitis. Important to note the presence of a lucid interval. And the management, and this case should not be can be easily managed with a general ophthalmologist. Management will be with a lid hygiene, meibomian gland dysfunction treatment, lubricant, and low-dose steroids. Now coming to the systemic causes. So the systemic causes can be autoimmune, dermatological, inflammatory malignancies. In autoimmune, you can have rheumatoid arthritis, vaginous relapsing polychondritis, systemic lupus erythematosus, polyarteritis nodosa, Sjogren's, dermatology, and the list goes on. So the gamut of a peripheral ulcerative lesion can be as severe as Murtaza to as mild as just a chronic contactless user presenting to us with just a dot-like infiltrate. You can also misdiagnose as a degenerative condition with a PUK, degenerative condition like Terence marginal degeneration. Terence, usually you will have a lipid deposition at its advancing edge, and there will be superior limbus involvement. Whereas in PMCD, like persistent marginal degeneration, you will have inferior corneal thinning, and sometimes this thinning can be so advanced that it can give rise to a hydrops or a perforation also. So whether it is infectious or non-infectious, that is the question. So why we need to know whether it is infectious or not? Because steroids are the mainstay therapy in a non-infectious case, as well as 50% cases are associated with collagen vascular disorder that will need systemic immunosuppression. Also, one need to differentiate whether it is a Murens or as a systemic immune PUK. So Murens was described by Watson's criteria. There should be no scleral involvement. There is no scleral involvement in Murens, and it is mostly idiopathic in nature. And Watson proposed the classification into 3 types: type 1, 2, and 3. So type 1 Murens is usually bilateral and painful more than age 60. Type 2 is can be seen in young with more aggressive in nature and less painful. Type 3 is more of an indolent one. Whereas systemic immune PUK cases will have associated scleritis. And this picture is a lady with a systemic failure in case of a multi-drug resistant TB. And ultimately she succumbed to the systemic failure. So how to approach a patient with a PUK? So thorough history taking is necessary. Meticulous clinical workup. You should never fail to check the corneal sensation, tear film, meniscus, as well as adjacent lid and adnexa. Corneal scraping, yes, definitely. Whenever in doubt, you should do a corneal scraping and culture. And detailed systemic investigations when you suspect systemic cause of PUK like ESR, CRP, ANA blot, CBC, because you will be starting immunosuppression. Also, cross consultation with rheumatologists is very essential whenever you are suspecting a systemic cause of PUK. So, coming to some variable cases of PUK presentation. This was a lady of 55-year-old came to me with active PUK in her right eye, and other eye already lost and under phthisis. So there was a perforated peripheral ulcer in the superior limbus, and her ESR and CRP were raised. RF factor was found to be positive, and we did a crescentic graft, also familiar, very well known as banana grafting with cataract extraction, because she was having hypermature cataract. And we could be able to restore her vision. She was doing well on topical as well as systemic steroid. But after 2 months, we can see there again the edge started showing an active infiltrate here. So we stepped up the steroids and immunosuppression, and the patient got lost to follow. Then after 4 months, she again presented with a total AC collapse with central advancement of the ulcer. And at this time, we consulted with the rheumatologist, and she received some 5 doses of IV cyclophosphamide, that is endoxan, along with her anti-rheumatic drugs. And she underwent a penetrating keratoplasty. Importantly, I didn't remove the banana or the crescentic patch graft which I had placed previously, because it had got scarred very well and was blocking the conjunctival vessels to grow over the cornea. So as of now, this patient, she is doing well, and she is on topical as well as systemic steroids. Now, this is again a case of a 94-year-old gentleman who presented on day 1 with a very aggressive peripheral ulcerative lesion. However, his relatives were reluctant for patch grafting just on day 1. So again on day 2, when he presented, the melt had increased, and even the iris tissue prolapsed. And on day 3, he underwent a patch grafting. So he was doing well on topical as well as systemic low-dose steroids. But you can see on day 14, again the side port started melting, and there was melting beyond the patch graft area as well as in the central part of the cornea also. So aggressive the nature was of melting. Now at this time, we consulted rheumatologist that he will need a high dose immunosuppression. Initially he was reluctant because the age of the patient was 94. So, but then he gave a high dose immunosuppression therapy, and we did a regraft for this patient. And you can see after the regrafting and under cover of high dose immunosuppression, the eye eventually got quite well. This was a case of a 75-year-old male who presented with circumscribed corneal thinning. This was not a typical case of PUK. You can see circumscribed lesion with infiltrate at the margin, and we scraped it, but however the scraping was negative. Then we started on empirical antibiotic cycloplegics, oral doxycycline, as he was having some immune gland dysfunction as well. However, on day 3 when he presented, again the melting had increased as well as the infiltration. So we continued with our treatment line, that antibiotics and cycloplegics. But on day 7, he perforated, and we had to take him for patch grafting. Now again on day 15, he came with loose sutures and active melting at this time. So we thought, no, there is something occult systemic involvement. So this time he tested positive for Sjogren as well as RA factor. Now after starting only with immunosuppression, the graft melting was arrested, and he's doing well as of now on this topical as well as systemic immunosuppression. So this presented like a not a typical case of PUK, but a mixed picture secondary to Sjogren's. So this was a case of a 18-year-old boy who was referred to me for a perforated cornea at the limbus, and he didn't give any positive history of trauma.
Can you wind up, Murtaza? The time is up.
Yes, ma'am. So just madam, just 2 minutes. So the lid eversion showed grade 2 papillae, and we took him for surgery. So we found that there was a profound tissue loss, and he underwent a 4 mm patch graft for this tissue loss. And he did well initially for first 2 weeks. Then again on day 16, he presented with loose sutures and active corneal melting. So this time he tested positive for anti-CCP. And after consultation with the rheumatologist, we put him on pulse methylprednisolone therapy 500 milligram just for 2 days. And then only the graft got settled well. This was a very recent case which I was managing.
Just sum up.
I
Yes,
think,
madam.
yeah, please
Yes,
don't
madam,
extend your
yes.
time because
Yeah,
we
this
have-
was recently managing this case, bilateral Murans. He was not responding on topical steroid and lubricant. So just I did a tarsorrhaphy, depending upon the limbus involvement. And you can see that after day 7, the congestion had gone, and even the active ulceration showed very good progress, like the progression stopped. So you can see the change in the staining pattern also. Just only a simple tarsorrhaphy can work wonders in such cases. So now to sum up, so steroids are the mainstay therapy, but however, one should plan a long-term immunosuppression in such cases. And the biological agents, these are not new, and these are in use since 2001, and these are good in refractive cases. Surgical procedure, tectonic, and you can do well, but you need to put the patient on immunosuppression. So my take-home message will be just that clinical presentation of PUK can be variable, and that should be a specialized care, and always these cases should be collaborated with a rheumatologist, because these patients definitely need a long-term immunosuppression. Thank you.
Yeah,
Thank you so
thanks.
much, Murtaza. Your excellent presentations, but you should stick to your time. Next.
You very nicely brought up the control of systemic autoimmune disease, which has to be done. In one of my patients of RK, I was surprised after a month she came with a scleral melt. And I said, I didn't do anything to the sclera. Why did she come with a scleral melt? So we investigated. So she had a rheumatoid arthritis, which had flared up. And that is how she. So once the rheumatoid arthritis was taken care, the scleral melt settled.
Sometimes, madam, post even pterygium surgery also
Yes. Yes. Yes.
Yeah, anti-inflammatory. People are continuously using these anti-inflammatories. I think one must be very careful how much you can use and how far you should use that. Well, yeah, next.